Okay.
All right. We have only an hour for the presentations, but that will be followed by a question and answer or discussion time. So I'll refer you to the meeting notes link you received. Well, it's on the chat if you didn't receive it in your meeting invitation. Um, yeah. COVID-19 has disrupted our lives, and in addition to being deadly for seniors, especially those in care, it has exposed underlying faults and failures of our social safety net. It's becoming obvious that our federal government, which often seems far removed, is an important element in our governance and our protections. Patricia Paradis is the executive director of the U of A Center for Constitutional Studies. She is a lawyer and an educator with honors and awards to recognize her work to defend and elucidate Canada's Constitution and Charter. There is, of course, a more detailed biography of each of our panelists in the meeting notes. Heather Smith has been a prominent and respected advocate for our public health care system, as well as president of the United Nurses of Alberta for a lifetime. My early recollections of Heather's wisdom and influence was in the 1988 Alberta nurses strike in response to political circumstances which are now being repeated. Heather will trace that history for us. Sandra Azakar is the executive director of Friends of Medicare and everybody's friend, right? And a longtime community organizer and activist. Sandra, with her mighty assistant Alyssa, does the work of an army to keep us informed of the political impact on our healthcare system by this government. My best recollection of Sandra is that she was the perfect companion during the 2014 sit-in at the health minister's office while we waited for the police to throw us out. We are so fortunate that Dr. Pat Armstrong will talk about her research findings and the possibilities of rebuilding better and stronger. Among other honors, Pat is the Distinguished Research Professor in Sociology at York University and a Fellow of the Royal Society of Canada. I'm so impressed by her knowledge, wisdom, and mostly her common sense. Aidan, over to you.
Well, thank you very much, Carol. It's just a couple things. Once our presentations are over, we're going to be having a question period at the end. So any questions, you can go ahead and enter into the chat. As Bill said, you should be able to find that on your bottom bar between the participants and share screen icons. And yeah, with that, I will go ahead and hand it over to Patricia, our first panelist. Take it away.
Okay, thank you very much. Well, good evening. Thank you for the introduction, Carol. And I just want to begin by saying that I am not an expert on seniors or healthcare or continuing care or any of that, but I'm hoping that I will be able to provide some constitutional context for some of the discussion that you are going to have this evening. And I'm very pleased to be part of this illustrious panel of speakers, I must say. So what I will do is try to explain what jurisdiction the federal government might have to create conditions or impose standards for accountability on the provinces in their delivery of care to seniors. And I'll begin with the caveat that there is no easy answer to that question. So we'll begin then with the Constitution. We start at the very beginning. So now the Constitution Act, Canada's Constitution, divides legislative powers. And legislative powers, it means the power that the federal government or the provinces have to create laws, to make laws. So it divides legislative powers between the federal and provincial governments. And those powers were arrived at in the 1860s. I mean, that's when John A. Macdonald and Georges-Étienne Cartier and the founding fathers got together and tried to decide which powers the colonies were going to retain and which ones they were going to hand over to this newly created federal entity called Canada. And so they set out in Section 91 the federal government's powers. And Broadly speaking, Section 91 of the Constitution Act assigns matters that affect the entire country to the federal parliament. So examples of what's listed there, and if you go to if you Google the Constitution, you can find Section 91, by the way, it's all there. Examples include postal service, the military, currency. Some heads of powers were assigned to the federal parliament to ensure legal consistency, like matters related to bankruptcy, divorce, criminal law. As well, there's authority over unemployment insurance, telecommunications, banking, copyright law, etc. There are 29 areas listed, and health is not one of them. Now, going on to Section 92, Section 92 assigns provincial heads of power, is what we call them. Generally, these are matters affecting a single province, and they include, for example, the establishment and maintenance and management of public prisons, hospitals, asylums, local works and undertakings, the solemnization of marriage, the administration of justice, such as the maintenance and organization of provincial courts, and matters that are of local or private nature in the province. So health, again, is not specifically mentioned in the list of the 17 areas that are in Section 92. Other than the jurisdiction to administer and maintain hospitals. However, healthcare jurisdiction is seen to be shared between the federal and provincial governments. That's how it's seen from a constitutional perspective, even though health is not explicitly mentioned anywhere in it. Now, with respect to provincial jurisdiction for health, and we know that the provinces have responsibility, Section 9216 assigns to the provinces a legislative authority over, quote, all matters of a merely local or private nature in the province. And Section 9213 assigns property and civil rights in the province. So that means that anything that's particular or specific to the province is going to be provincial. So obviously the administration and delivery of healthcare is the responsibility of provinces and territories. Now, the provinces and territories fund those health services with the assistance of the federal government in the form of fiscal transfers. And the delivery of healthcare services is guided by the provisions set out in the Canada Health Act. That's an act that was passed in 1984. And so how is it, you might ask, that the federal government has the authority to give transfer payments to the provinces when there's nothing in the Constitution that gives it power over health? Like, where does that power come from? Well, as it turns out, two of Parliament's important powers under Section 91 are inferred rather than enumerated. So they're not actually explicitly stated, but they're inferred. And these are the residuary power and the federal spending power. And it's the spending power that's most relevant to our discussion this evening. So the spending power is inferred from Section 91(1)(a), which is called the public debt and property, and Section 91 sub 3, the raising of money by any mode or system of taxation. So in the course of our history as a country, those two sections have been inferred to mean, they've been interpreted to mean that the federal government has the power to issue transfer payments to the provinces. Now, so the spending power forms the basis for federal grants to provinces and allows Parliament to spend funds outside its areas of legislative authority. So you can imagine that this causes a few problems, because the feds might want to get into dictating to the provinces this or that, might issue transfer payments and make them conditional on who knows what. So there have been a lot of battles about this over the years. Now, in the health area, transfer payments are through the Canada Health Transfer, and they are subject to the principles set out in the Canada Health Act, that provincial health plans, for example, must adhere to the conditions that are stipulated in that act. So CHT funding comes with strings. They are linked with provincial compliance to regulations in the Canada Health Act. Now, historically, the federal government has applied a range of conditions to health funding. It transfers to the provinces, but it is obviously necessarily sensitive to arguments that the delivery of healthcare is a provincial jurisdiction. Now, of importance to the discussion this evening is the fact that continuing care, long-term care, is not specifically included in the Canada Health Act. It's not part of the conditions included in the transfer payments to the provinces. It was there at one point in language that talked about extended care, and that was taken out in 1995. Now, there's a long history of how federal transfer payments have been made. And as I said, as you can imagine, there's a pretty big political component to the whole concept of transfer payments. And what I've done here is just listed some of the history of transfer payments. And I'm not going to get into it all because we don't have time, but just to give you an idea, in the years before 1954, Ottawa made a long series of important decisions that brought about spending programs entirely financed, regulated, and administered by the federal government in areas of provincial jurisdiction. These programs were unemployment insurance rather, it was called, family allowance, and old age pensions. And after 1954 came even more significant spending programs, hospital insurance, Medicare, and social assistance, but those later programs were cost shared with the provinces, but of course provincially administered. And this shift, by the way, from entirely federally funded, regulated and administered programs to shared cost programs in that era served as a bulwark against federal takeovers on social programs in provincial jurisdiction. Whereas in the fullness of time, those shared cost programs are themselves typically now viewed as having the potential for trampling on areas of provincial jurisdiction. Now, I should note, by the way, a lot of people don't realize this, that in the Constitution, jurisdiction for federal jurisdiction and provincial jurisdiction are considered equal. The federal government does not have control or power over the provinces. They are considered completely equal. So one will take the other to task or take the other to court if indeed it feels that the other jurisdiction is trampling on its jurisdiction, and that happens frequently. Now, I just wanted to point out in 1996, 1997, the Canada Health and Social Transfer. That is when the government combined the EFP, or EPF rather, Established Programs Financing, and the Canada Assistance Plan into a block transfer to the provinces. But this was when the government was trying to lower its debt and reduce spending, et cetera. So it significantly reduced the amount of transfers to the provinces. And in fact, it was something in the area of 4.1 billion or something like that. So there was there was less accountability required of the provinces, and that is when they deleted extended healthcare services programs from the transfers. So it gave the provinces more autonomy, but it also gave them far less money, and so the federal government came out looking great in the end, but it resulted in a situation where the provinces became extremely grateful and thankful for transfers coming from the federal government because they had been cut so significantly. So as I say, these transfer payments are part of the Constitution, but they are fraught, politically fraught, is what I'll say. Okay, now I'm just going to conclude here. And just to say that, just to let you know, if like there's no straightforward way for a decision to be made as to whether or not something is provincial or federal. Any disputes in that regard have to go to the courts, and the courts are the ones who make those decisions. And they use several tools, and one of the tools they use is called the pith and substance doctrine. It sounds a bit odd, but pith and substance is really where the courts actually look at an act, a piece of legislation, So let's say, for example, the province of Alberta passes an act that stipulates that if you commit some offense, you will be incarcerated for X number of days or months or something like that. And the federal government sees the law and says, you know, I think you're actually trampling on federal jurisdiction here. Criminal law, that looks like criminal law. And that is our jurisdiction. So that might be considered by the courts. So the courts will look at the pith and substance of that law. Does it actually go to the heart of federal jurisdiction? Is this actually criminal law? And they look at the wording of the act. They look at sometimes debates that went on in the legislature as to why the act was created in the first place, et cetera, et cetera. And then we'll decide whether or not it is primarily federal or provincial jurisdiction. So that's one of the ways in which the courts will make a decision as to what is federal, what is provincial, and how those are tramped, or how there is tramping. Now, so no straightforward answer as to what is federal, what is provincial. But I did want to just leave you with an interesting bit of information that I came upon this week, actually. I was sent a copy of a resolution being passed by the Canadian Bar Association Elder Law Section. And so the Canadian Bar Association is an association of lawyers across Canada. It has about 35,000 lawyers in it. And they have an annual general meeting at which they pass resolutions, and the resolutions are meant to be policy statements for the organization. And the elder care section, so there are several different sections in the organization, but the elder care section is posting a draft resolution called Improvement of Long-Term Care and Support for Older Canadians. And what they're doing is whereas the COVID-19 pandemic has had a disproportionate and tragic impact on the lives of seniors, et cetera. I won't read the whole thing for you, but they come up with several whereases, which are about what's going on in the country right now and the exposing of the terrible conditions for seniors. And they say, be it resolved that the Canadian Bar Association urge the federal government to. And so one of the things they ask is a fast tracking of the establishment of national quality standards in long-term care and ensure appropriate resources for enforcing them. Create a pan-Canadian health and human resources strategy for long-term care and broader continuum for care for seniors, and on and on. One of them is improve infection and prevention controls in long-term care, including adequate supplies of vaccines recommended for seniors. And the reason I'm putting this out to you is just because this resolution is now going to go through all the different sections of the Canadian Bar Association, including the constitutional section. And I suspect, and I spoke to someone in the elder care section this week, there already is some debate as to whether this resolution can pass as it's currently worded, because there's concern over the fact that it looks as though some of these recommendations are tramping on provincial jurisdictions. So for example, improve infection prevention controls in long-term care might be seen to be tramping on provincial jurisdiction if the federal government decided to. And I'm not suggesting that that's the case, but there will be arguments made about the fact that the resolution probably goes too far. So these are ongoing debates, these federal provincial debates, but I'll just leave it there and look forward to hearing the rest of the panelists. Thank you.
Wonderful. Thank you very much, Patricia. I just want to remind everyone, of course, once all the presentations are done, we will get to all your questions. I'm just going to keep a note in the chat here. And our next panelist is Heather Smith. She's the president of the United Nurses of Alberta. And take it away.
I'm going to be sort of general and hopefully brief, because I too want to get to the question and answer portion of tonight's meeting. And thank you, Pat. That was really good. I do have a question for you coming out of that, but I will come back to that. I just want to say that in terms of where we are today, it's no accident. This has been an intentional journey created by political decisions and policy decisions that go back over 3 decades. And it has been, as I said, very deliberate. United Nurses of Alberta as an organization, actually, we had our first conference on long-term care. When the first conference we had was specific to our members, but it was as a result of concerns that were starting to become bigger and more worrisome in terms of availability and quality of care for seniors. And that our first conference on long-term care was actually in 1999. But even going back before 1999, and the reason we had a conference in 1999 was basically because of decisions that started to be made in the late 80s. We don't have a lot of legislation here in the province in terms of long-term care, and we've had a real evolution in terms of what long-term care actually looks like. When I came to the province in the late 70s, a lot of individuals, seniors who had complex needs were in fact looked after in acute care hospitals. They may eventually have gone to something called an auxiliary hospital in terms of recuperation and that kind of thing. But if you looked at the profile of who was in what we called a nursing home or a lodge, it's very, very different from what evolved over the upcoming decades. So we had an intentional decision made by politicians here in the province to offload, to shift responsibility and cost of care from the healthcare system generally to individuals and their families. If you think back to the end of the 1980s, we started to hear a lot about concern about the gray tsunami, the baby boomers that were going to overwhelm the system, the costs that would be associated with that. So there have been very deliberate steps that here in the province to change who pays and who's responsible. One of the big pieces of sort of policy, well, there's two, Diane Mirosh in the late 80s, Mr. Broda, MLA Broda, in 1999. And in the Broda report, which sort of took off where the Mirosh report left, it was very clear that they were talking about, status quo is not an option. They talk about unbundling the costs, and that's really where we started to see the movement to for individuals to pay for their accommodation, and ultimately, in many cases now, actually be responsible for paying for what we would have considered care. We had at the same time an overall reduction, a significant reduction going through the 90s of acute care beds. We didn't have significant growth in terms of long-term care beds, but what we had, in fact, was the sort of invasion. Well, it wasn't an invasion. They were invited in by government policy. We invited in private operators in terms of alternative housing for seniors. And that has, aging in place and that kind of stuff in terms of suggesting that, seniors with healthcare needs were no longer appropriate in acute care, especially when we reduced the number of acute care beds. That they had, they belonged somewhere else. And in fact, they made them start to pay for being in an acute care bed in the 90s because of that, wanting to shift them away. What we didn't have, though, was we didn't have a sort of a growth in terms of an appropriate growth in terms of supports. In fact, we lost a lot of dedicated resources for home care and that kind of stuff for seniors to keep them in their homes. And we're pushing more and more seniors into an assisted living kind of environment where they would pay for what they might have previously received in a hospital or an auxiliary hospital. The standards for long-term care actually are very minimal. They were set in the late 1980s, and they have not changed since that time. And they only apply to nursing homes, although somewhat loosely are also considered to apply to auxiliary hospitals. We had several auxiliary hospitals in the 1980s, 1990s, and in fact today we still have many auxiliary hospitals, several of them here in the city of Edmonton. And auxiliary hospitals, there's an interesting loophole that the nursing home standards, the nursing home regulations actually don't apply to auxiliary hospitals or acute care hospitals. So we ended up with a situation that we have today where in fact, there is less requirements there's no requirements in terms of minimum hours of care. There's no requirements about minimum staffing for auxiliary hospitals, even though you would think that auxiliary hospitals are in fact have seniors and others, but primarily seniors who have a greater set of needs, more complex set of needs. And we've seen this whole shift as we've reduced acute care to the complexity that now exists, particularly in long-term care and auxiliary hospitals. But this was quite intentional. This was intentional, I believe, to remove government from accountability, financial accountability, and ultimately oversight. Just a couple of things I want to read to you or pull out for you. And by the way, our second conference on long-term care we had in 2012, and Carol, I'm sure will remember, it was called Beyond Acute Care. And we did a lot of talking in terms of how things have and have not changed in terms of quality for seniors. One of the things I wanted to point out is that we've had lots across Canada and in Alberta, we've actually had a lot of looking at long-term care, but not doing anything around long-term care. And one of the things that is repeatedly pointed out is the 2005 Auditor General of Alberta issued a very scathing report on seniors care and programs, pointing out that the basic service standards are out of date, monitoring and compliance is inadequate, and 30% of facilities did not even meet those care standards. And we have very, very basic standards, and we do not have adequate oversight and follow-up. We don't have, you can't just go into a long-term care site in terms of doing an inspection. So I mean, we fall apart on so many levels in terms of abdicating our responsibilities to seniors, but it has been intentional. We have offloaded responsibility and cost to them. There's one of my colleagues is actually has written an article that is it's a book chapter that it's currently in the press. It's out there, but I just wanted to make a couple of comments because I think this is really important for today's this space we're in right now. And she writes, in the early stages of COVID-19 pandemic in 2020, citizens rushed to supermarkets in panic to buy toilet paper. This crowd behavior provides insight into a deeper reality, that it is thought that the thought of being forced into prolonged, inescapable contact with one's own excrement is universally feared. As the pandemic continued, it became obvious through media reports from journalists and many others that the incapacitated residents in Canadian nursing homes were particularly endangered, not only by the appearance of the new virus, but also by the existing conditions of neglect in which they have been living in intentional neglect that has been going on for decades. And what we have, in fact, is normalized neglect for seniors and other vulnerable populations through a whole variety of institutional and government policies in terms of, institutional decisions to ration supplies and staff. We have had huge issues around the staff being told that a resident, I like to call them residents, and in fact, I insist on calling the patient, that patients are rationed diapers in terms of incontinence. We heard stories about staff being told they weren't to change the diapers. They may have only gotten 1 or 2 diapers a shift for a patient, and they were not permitted to change them unless they reached a certain level of saturation. So we have normalized neglect through administrative and policy decisions in long-term care right across Canada, and of course more concern in terms of the profit motive in long-term care. I'm just going to read the last comment from this paper as well, which one of the last comments. The actions of individual leaders at various levels of the long-term care hierarchy can influence caregiver practices and sometimes prevent neglect and harm. But if hygiene and human dignity are not priorities and dictated from the top, the individual efforts of well-motivated caregivers will remain random acts of kindness in a system organized, in this case, like the death camps, for bureaucratic efficiency. So this is a dilemma, a situation of intentional neglect that we have created right across Canada, but certainly right here in our own province. And I'll stop there.
Thank you very much, Heather. Next up, I'm going to bring on Sandra. She's the Executive Director of Friends of Medicare. And after you.
Thank you. Thank you so much. I feel very humbled to be able to speak today on this very important topic. As Heather mentioned, this crisis in what we're seeing in seniors care is not anything new. It certainly has been in the making for decades. And I think if anything, this pandemic has shone a light on the grim reality that we have in the area of seniors care. When a system is under stress, is when we see the cracks, and COVID has definitely put that stress. I just want to talk about a little bit of what we have seen in the last year. It seems like that we've been under this COVID thing forever, but and lots of things have happened while we're all worried about our families and our communities, and this government has been relentless in basically following their ideological basically route to privatize some of the areas that pertain to public health care. I'm just basically going to focus on seniors care. So let's set the stage. We go back to the election platform that the UCP put out, and the only place where they actually talked about seniors was where they indicated that they wanted to make life better for seniors and their families by using the Affordable Supported Living Initiative, ASLI, to build the long-term care beds that we need in this province, and encouraging more home care options and maintaining existing seniors benefit. That's quoted from their platform. Just remember that, because it down the road, we kind of see where they have gone with this promise. So in 2019, we elected a government who's, if anything, they've been very clear with Albertans about their intention and their plans for Alberta's public services. And we have seen an endless ideological quest to privatize. In May of 2019, they appointed Janice McKinnon to the chair of the Blue Ribbon Panel. And they were only tasked with looking at expenditures, not revenues. And they were tasked with recommending a path to a balanced budget by the year 2022-23. Without raising taxes. In the area of healthcare, the panel recommended transformational change in the way healthcare services are delivered and healthcare professionals are compensated. We were the most concerned about the fact that they were recommending an expanded role for private healthcare in Alberta. And of course, now you have seen throughout this year the impact that this recommendation has had on the way that not only physicians are compensated, but nurses and other healthcare professionals. On July the 9th, without any surprise, Minister Chandra announced on Twitter that the Affordable Supported Living Initiative would continue under the UCP government. And what's important to kind of rescue from that announcement is that currently the Affordable Supported Living Initiative allows the government to provide up to 50% of the funding for construction costs, followed by operational costs to run privately and non-profit facilities. So the province we don't own it. We don't own the buildings. And once the contracts expire, the public must buy the building back at the market price. And this initiative has resulted, if anything, in the aggressive privatization of Alberta's continuing care system and the erosion of higher acuity long-term care in favor of expanding more lucrative and under-regulated designated supported living facilities. Then we move forward to February 2020, when the government released a $2 million much expected review of Alberta Health Services by Ernst & Young, with a focus, and their focus was economics and finding efficiencies in the system. And this report contained 57 recommendations that by their estimates could result in about 1.9 billion savings. Although Minister Chandra at that time, to be fair, indicated that not all recommendations were feasible and not all would be implemented. So this report basically provided an ideological fodder for this government to start the process of privatizing our healthcare system. And it made, when it came to seniors care, the recommendations that were made would only serve to perpetuate the crisis we have in the seniors care system right now. Among the recommendations was the sale of Care West and Capital Care to private providers as a one-time revenue source. And the report suggested that Alberta could see an estimated savings in the hundreds of millions of dollars through the sale of these two public care providers. But we have never yet seen any real numbers or any consideration of the potential impacts that a sale like this would have on the working and living conditions at these sites. Further recommendations, including were proposals to introduce a co-pay for certain home care services, increase accommodations fees for continuing care, and shift more patients from long-term care to designated supported living. But not only shifting the patients, but also transitioning some of these long-term care beds to designated supported living beds across the province. And in an initiative, initially they had indicated a saving of about $7 million a year. What this means is that most the people that are currently needing 24-hour care for unscheduled medical needs would be moved into lower levels of care and magically cured from whatever it is that they're having to deal with in their lives. It would mean that residents would be considered to have a lower staffing need and would remove, for example, the need for RNs from seniors care. And as Heather mentioned, staffing is one of those areas that has long been overlooked in the continuing care system. Long-term care in Alberta rarely meets the benchmark criteria for minimal acceptable cares, and private facilities have the greatest average of deficits below minimal care. And these deficits definitely put patients' health at risk. And as we have seen during this health crisis like COVID, this risk increases exponentially. So with these two reports in hand, the world and Alberta gets hit by a pandemic, the economy hits rock bottom, and it comes to a full stop. And in March, of course, at the start of the pandemic, the government pushed a budget through, which was based on unrealistic forecasts for oil prices and subsequent government revenues. And just on a side note, on March 1st, 2020, as a result of budget 2019, 46,000 Albertans were left without drug coverage as the government ended coverage for dependents under the Alberta Seniors Benefit Plan drug program. On April 1st, 2020, while we were all focused on the beginning of this pandemic and trying to deal with it, very quietly, the recommendations that were made started happening. Seniors taking driver's medical exams are now having to pay that out of pocket. Referrals by some practitioners for publicly funded diagnostic imaging is now uninsured, so it's not covered. And physicians were no longer able to submit good faith claims, leaving the most vulnerable people like the homeless and people that don't have their IDs without any kind of support services and relying solely on the goodness of doctors who provide services. As well, Sage Health Services closed, leaving over 500 seniors without community access to primary care. And in April of 2020, we heard of the first death in Alberta's continuing care system. And as of January 28, 2021, out of the 1,606 COVID-19 related deaths, 1,047 have been facility residents. That's 1,047 seniors that have died in this province as a result of COVID-19. It's definitely taken a toll on our continuing care, this pandemic, and it's both, like I said before, many of the cracks. We have for decades, along with our allies and seniors advocacy group, have sounded the alarm on issues facing this area. We have repeated called on the governments to get profits out of seniors care and to enact patient staff to patient ratios to deal with the unsustainable workloads, which only help to lead to burnout for the staff. This has even made even worse by the fact that families are no longer able to go into these facilities to assist the staff. It has created people being left without the care that they need. And we have been hearing horrible stories about people, having to do without because there's not enough staff. There's also been the situation where anytime that there's an outbreak in the facilities, when one staff is off, having to isolate, that it usually impacts about at least 4 or 5 other staff. So again, this has been an incredible concern. We also have seen that over the decades, the drop in funding, where staff do not only provide personal care, but are also tasked with housekeeping duties, has only served to increase the possibility of cross-contamination. So there's all kinds of issues that are related to the staffing or the lack of appropriate levels of staff within in our seniors care. And the current funding structure creates an incentive for both not-for-profits and especially for-profit providers to pursue low-wage strategies for their staff, which is why we have so many staff working in 1 or 2 sites, or sometimes working in one healthcare setting and then having to go somewhere else to work in the community, increasing again the cost, the chance of cross-contamination. And what we have seen throughout this pandemic is the impact of our government's inaction to unfold the devastating effects of COVID-19. And this is all within a context of the premier that, while speaking at the legislature, stressed that most people who died of COVID-19 have already outlived Alberta's average life expectancy. You know, he indicated that the average age of death from COVID in Alberta is 83. And he reminded the House that the average life expectancy in the province is 82. So really, you know, we are doing much better than most because people are dying past their expected life expectancy. So what has been their response? On April 20th, after we saw the first death in seniors care, funding was made available to hire or to get more temporary staffing of healthcare aides in continuing care facilities. We gave them $24.5 million in an advance to operators to address immediate cost pressures. This was supposed to go to a wage top of an additional 2 hours per healthcare aides, and up to 1,000 paid student practicum positions were added to fast track certification. There's still concerns that some people haven't even received those 2 hours per the top up hours. And we know for a fact that the government has left millions of dollars on the table from federal money that could have actually gone to help and improve not only the paid sick days of people working in this area, but also to top up their wages so that they don't have to work in multiple sites. On top of that money, in May, the government made a further announcement committing to $170 million to contracted continuing care facilities, so that's private and not-for-profit, to offset the loss of revenue that has resulted from this pandemic. the government at that point said that they would require to report on the use of these funds, but yet we haven't seen that, any of that, and there's no indication that this reporting will even be made public. So that, just keep in mind that we've given private operators over 200 million since this pandemic to subsidize a system that is truly in crisis without asking them to be accountable. And we know, for example, that companies like Chartwell paid millions of dollars of their to their shareholders, even though they've been getting money not only from provincial governments but also by the federal government. On August 20, Minister Shandro doubled down on his privatization path, and he introduced a new approach to build more seniors care facility. He indicated that the first part of this approach would involve a mere 1 month long bidding process to corporations and not for profit organizations who could identify underutilized spaces in existing buildings and to become new publicly funded, privately delivered continuing care beds. The government could not tell us at that time how many new beds this program would secure, how many additional staff would be needed, or how much it would cost the public. And then, of course, the next phase of this approach would include more grants under the ASLI 2.0 program. Again, details have not been reported as of yet, but you know what the ASLI program is all about. And for us, this is a time where we need to seize the moment. We're not seeing any just actually, to be fair as well, just so that you know, most of these changes that I mentioned or recommendations that I mentioned were put on pause until the outcome of the continuing care based and facility based review. What they're going to do is take all the legislations that currently rule or basically regulate seniors care and put them under an omnibus bill, which is what this government has gotten in the habit of doing, and basically create one omnibus bill that will oversee the regulation and the way that this system will be, or the services in the system will be provided. We, Friends of Medicare, along with Public Interest Alberta, are currently engaged in a campaign called Alberta Seniors Deserve Better, and we're hoping to get this conversation happening. This is a moment where we need to seize the day and not continue to allow this crisis in the way that we provide services to our loved ones to continue. We need to learn from this pandemic, and it's a very timely opportunity that we have to push for changes. We're also working with our allies across the country with a continuing care collective. Our first part of our campaign was make Rivera public. The reason why we picked Rivera was because, as you have heard, in Ontario and down east, the majority of the deaths have been in places like Rivera and Sienna Living. And so we thought it would be a good start to have a campaign that could focus on one specific, and also because this specific operator is also not fully owned, but it is funded through the pension plan of the public services workers, and I'm sure Heather will correct me in that, but that's why we thought it would be a good way to kind of make this conversation start happening. The way that we think is that it's imperative that we not, like I said, not return to the same old structure of continuing care that allows corporations and their shareholders to profit massively at the expense of Alberta seniors or Canadian seniors. This is a health crisis that we need to learn from and definitely reevaluate our values.
Thank you very much, Sandra. We're going to go next to our final panelist, and then we'll have some time for questions at the end for our panelists. Next up is Pat Armstrong, distinguished sociology research professor at York and a fellow of the Canadian Royal Society. Take it away.
Thank you. And thank you for inviting me here and for the work all of you are doing and those incredible presentations. I feel like right now I need a drink after all of what I've heard. I've been leading a team that's international, actually, that includes Norway, Sweden, Germany, the UK, the US, and Canada, to try and reimagine long-term residential care. And part of what I want to talk about is where we think we should go from here. And we would argue that going from here means the involvement at the federal level, the provincial territorial level, and the local level. We need all three involved in transforming this sector. And we start with a lot of principles, but let me just name several of them. One is that we have a basic human right to care and a shared responsibility to care. Another is that care is understood as a relationship, and that leads to all kinds of implications about how we organize the provision of care. We would also argue strongly that the conditions of work are the conditions of care, that we can't improve care, we can't make it person-centered, as so much of the conversation is about, without also focusing on the people who provide the care and the conditions under which they do that. And we would also argue that all of those who work in a long-term care home are care workers, and that we have to include all of them when we are thinking about transforming care. That it has to be in turn embedded in a longer care system when we are moving forward. So those are just some of the principles. And we would also argue that we have to take equity into account, both in terms of the provision of care, and in terms of those people who do the care work. So in the paper that was put up in the chat and was distributed, I think, beforehand, we set out some standards that we think could be introduced at the federal level. I know that some of the premiers have said that the federal government has no business in long-term care. We just heard an eloquent description of what the constitutional issues are. The premier who said the Fed should stay out of the provincial provision of long-term care said, what does the federal government know about long-term care? But from what we've just heard, I think we could ask that of the premiers. What do they know about long-term care? Because they certainly haven't been providing good long-term care. And I would argue strongly that we need all of three levels involved, and we need some federal leadership in terms of standards that follow the same kinds of ideas that we followed when the Canada Health Act was set up. So let me set out 7 standards that we suggest in this paper, and I hope that we can have some discussion on them. The first is access based on assessed care needs and not on ability to pay. Right now in Canada, and it's hard to find this out, although we did produce a paper in our project about what you pay in which province and territory across the country under what conditions. There are considerable variations. But basically, you're not prevented from going into care because of your own money, although we certainly, as Heather said, transferred a lot of costs. It's primarily because there are not enough beds in the publicly funded care homes. And this goes back to what Sandra said as well. So we need more beds, and we have to have a standard in terms of wait times to direct that would indicate that there have to be sufficient beds to dramatically reduce the wait times we have now. Secondly, we need, and of course we've heard this too from both Heather and Sandra, minimum staffing levels. We would argue that it should be based on current research and on verified data, because we shouldn't trust the employers to provide those data. It should be verified that those are worked hours, and that those hours should be based on an understanding of clinical, social, and emotional needs of the people who need care. We have to include all three. According to Charlene Harrington, who has been part of our research team and is an international expert on questions around minimum staffing hours, we should be talking about more than 6 hours per resident per day, given the complex needs of residents in care homes now. No province has minimum standards that go anywhere near that. And in fact, the 4 hours that are being pushed by many of us are right now seem out of reach. But what is actually being provided is about half what Charlene and her research team would say. The third principle is that we need to ensure that 70% of the staff are full-time employees and that the other 30% be permanent part-time employees. We need some flexibility through part-time work, but those people, all of those people, the full-time and the part-time people, should have permanent jobs that are provided with decent working conditions and decent pay and decent benefits, as we've heard from both Heather and Sandra already. And that pay should be based on equity principles. I interviewed a human resource director in Norway, and I asked her if she was in charge of the system, what would she do? She said, if I was in charge, I would pay the women, and it's mostly women who work in long-term care, what we pay the men who work on the oil rigs, because the women who work in long-term care work harder. And she had just come from their public broadcasting system, actually. The fourth principle, I would argue, is that we have to have minimum standards for the physical environments that ensure not only safety, but also social support for residents, staff, families, friends, and volunteers. And one of the things we talk about in our work is that we have to consider all of those who live in, work in, and visit in long-term care when we're doing this kind of planning and when we're organizing our decision-making. And by physical environments, we don't just mean the way the building looks, although that of course is important, but we also have to think about the food, the laundry, how the cleaning is done, and of course by other infection control equipment and measurements. I couldn't help but think when Heather was talking about as a paper we wrote that we called the thin blue line, about the blue line that is in the adult briefs that is supposed to, you're supposed to not change the diaper until it it's saturated up to the blue line, taking away all the decision-making power of the people who are providing care and of the person who needs care based on the technology. And if you've tried those adult briefs, you would see why this is a problem. My fifth of our 7 standards is education and training standards that support the existing staff as well as new hires and are developed in partnership with the public post-secondary institutions and organizations representing the different categories of workers within them, like the nurses union, etc. And that we would argue that we have to provide education and training as well for all of those family members and the visitors who come into long-term care. And that's of course been an issue, as we just heard, in terms of long-term care, in families coming in to provide the care. And I would argue that the absence of families is yet another indicator of the huge gaps in care that they have been forced to fill as well. My 6th point has to do with, again, we heard this from both Heather and Sandra to some extent, we need transparent, verified reporting to assure accountability to the public, and it has to be accessible data. And we have to ensure compliance through inspection and not just through reporting. So that means regular public reporting on inspections that include enforced penalties for failure to comply with the standards. And the public reporting should make it possible to learn and improve rather than simply punish. And finally, and this relates very much to what we've heard from both Heather and Sandra, we need a plan to ensure that all public money goes to public or nonprofit organizations. And that has to include subcontracted services. It has to mean that the food is cooked and prepared and delivered in-house. that the personal laundry is done there, and that the house cleaning staff are part of the team and not a subcontracted service and another source of profit. So thank you. Those are the standards that we are suggesting. Of course, they're not written in stone and are open to advice and change by others, but they do grow out of the many years that we've been involved in looking at care in these many countries. So I look forward to your questions and hearing other people.